Call us at 1-888-376-6225. Send an email to ask@prairiedoc.org or engage with us on our Prairie Doc Facebook page. We will do our best to answer as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All of your questions will be anonymous and no information is saved. If you would like to leave your name, email, or phone number, you will be entered into our drawing for our Prairie Doc publication, Perspectives from the Prairie. However, it's not a requirement to submit a question. We'll announce the winner at the end of the program. So thanks to email and Facebook and even some phone calls, we've got a bunch of questions already. And some of them have to do with cold and flu season, as we are right now. What are you seeing in Madison for this cold and flu season?
Yeah, so definitely we're experiencing an earlier influenza season than we typically see in South Dakota. So I think we're seeing that across the state. Increased influenza hospitalizations especially. Both influenza A and influenza B are going around pretty rampantly right now. Some COVID here and there. I haven't seen a lot of RSV necessarily yet. I don't know your guys' experience with that so far, but definitely a lot of influenza.
Yeah. What are people experiencing with the flu?
A lot of times headache, body aches, fever, chills, low appetite. Sometimes with influenza B there can be more GI symptoms, some diarrhea, vomiting, those types of things.
What do you recommend someone do when they come down getting sick?
Yeah, so definitely we recommend trying to stay away from others to prevent the risk of spread. Certainly there are groups that are high risk, and so you may want to consider reaching out to your physician to get seen early. There are medications that we use to treat infections such as influenza. They do require being started early, within 48 hours of that symptom onset, but not everybody needs treatment for influenza. So if you're otherwise healthy, not a lot of other medical problems, you can treat symptomatically with just staying well hydrated and using medications like Tylenol, ibuprofen to treat symptoms.
And if someone is pretty healthy and decides they're going to push it out, at what point do you recommend they do come in?
If you are getting worse after a couple of weeks and not getting better, if you're unable to eat or drink or keep anything down and you're concerned about dehydration, those would be times where I'd recommend coming in to see us.
Yeah, absolutely. Yeah, give it some time, but if you're having trouble breathing and just something doesn't seem right, it's good to get checked out.
Right.
What do you recommend for prevention, Dr. Meyerink?
Well, the shot this year seems to be working well. We've definitely had a lot of positive flu cases in Sioux Falls and across the state, but the strong majority of my patients that have flu are ones that did not get the shot. So it seems to be working well. Otherwise, the main thing I say to watch for is fevers. If you are having fevers, you need to stay away from other people, and that will help prevent it probably better than anything. But Laura also mentioned RSV. Our case numbers have really gone down for that the last few years, thanks to the RSV vaccine as well. So I've only had one case so far this winter, and that is a low for me if it stays that way for sure.
I felt like an old doc the other day because I was thinking, like, my first time on call for pediatrics in residency, I admitted 26 kids with RSV, and now it's really helped. And even in Brookings, when I was here, we'd have a whole, a handful, but it's really helped.
And the RSV vaccine is not just for kids. We actually are really recommending it to the elderly as well. Most people think of RSV as a disease for children, but actually it can cause quite a significant respiratory illness in elderly adults. So I know a lot of our nursing homes have done a great job reinforcing that, and same thing there. I just have not had any elderly with RSV in a long time.
And so what age would you recommend someone consider the RSV shot?
So typically 65 on up for most people. There are some guidelines that you could do it sooner with certain risk conditions, but for the most part it's that 65 plus crowd where I bring in some of those things.
Yeah.
And for the pediatric population, there's two ways to protect infants. So we can give it in pregnancy, we can give the RSV vaccine to mom, or if they were not able to get it or they chose not to get it, then we also have a monoclonal antibody, which is a little bit different than a true vaccine, but it works similarly, where we can protect those babies who are going into their first RSV season and they're under 8 months old.
Yeah, so important, so helpful. I think back again to 2020 when we were, testing a lot for COVID. And it was an amazing number of times where sometimes it was RSV that was making someone sick. So then there were a few years we didn't see it, and then now the last few years have been, but not yet. But I bet it'll come. Yeah. So, well, we better jump into this. So sometimes someone gets sick, and this emailer said, "I'm a woman in my 50s early 50s, and recently had some sharp pain when I breathe in. If I cough, the pain goes away. It is not continuous, and Advil does make it better. It does not wake me up at night. Is this something that should be looked at, or is it just another virus? My whole house has, quote unquote, something the past 2 weeks. What would you recommend in that
This
situation?
sounds like many households in South Dakota right now. And so viral infections can do that. They can cause inflammation of the lung lining and the chest wall. And so sometimes, yes, it can feel very sharp, as this patient mentioned. But most of the time, things like Advil, sometimes even heating pads, basic interventions like that to help with inflammation and then time will alleviate it. But if it's getting worse, certainly if it's waking up at night, your breathing's getting worse, then at that point, that's why I'd say, hey, you should probably go get seen by someone and just make sure there isn't something more significant going on.
What would you be looking for in that situation?
Yeah, so things that would be more ominous in that situation would be if you're coughing up blood, if you're starting to feel short of breath, if your resting heart rate is greater than 100 beats per minute, you've got swelling, especially if it's just in one leg or the other, or you've got risk factors for blood clots, which would be, maybe recent travel where you were in an airplane or a recent long car ride. If you have any cancer, underlying cancer, that can increase your risk. But those would be potential life-threatening things that could cause that chest pain. But a lot of the times it is something as simple as some related to a virus, just some of that pleuritic inflammation.
Well, I can really tell you guys have done this before. You guys are knocking it out of the park here.
It's our day job.
From Facebook, this person said, recently my shoulder hurts when I lift it certain ways up. Ice helps, so does Tylenol. How long do I rest, ice, and pain relievers before I should go in? Is this something serious that should be looked at? The pain is not sharp, and mostly when I move my shoulder around. A 55-year-old woman. What would you recommend there for that type of shoulder pain?
So the age is helpful there because a lot of middle-aged people will have this probably multiple times throughout their life. And most of the time it's inflammation of either the rotator cuff tendons or a bursa underneath of them. And so it can be quite painful and limiting, but rarely do we need to jump to orthopedics and surgery and things like that. And there are some great resources online for even just some basic stretches and therapies at home. If you need things by mouth, NSAIDs, Tylenol, if you can take those, heat, ice, alternate. Time usually does help, but if you're starting to feel weaker or it's not improving, I definitely would go be seen by someone because there are times it could be something surgical, and the majority of these can actually resolve with physical therapy, who I'm sure are all huge fans of and proponents of. And so your physician or provider could happily refer you to that, which I would say solves probably 80 to 90% of these types of scenarios.
Yeah, I think I remember seeing a study one time where a large percentage, anyway, of adults this age and older, if you did an MRI of their shoulder, it would show some rotator cuff tendonitis, tendinopathy, which can cause some of these symptoms. And thankfully, physical therapy helps. So it's worth doing.
And oftentimes, just because of this reason, imaging, we don't need to jump to right away. So a lot of times, we can diagnose this based on physical exams. So if you go see your doctor and they maybe don't think an x-ray is needed, it's because we don't see those tendons, we don't see the burst on an x-ray. And because most of it gets better with conservative therapy, really an MRI is going to be way down the line if we start to think there might be something surgical that we would need to do an intervention for.
Absolutely. We'll move down the shoulder to the wrist. This emailer says, I have wrist pain that seems to shoot up my arm sometimes with movement. It comes and goes. What could be causing this intermittent pain? So this wrist pain that shoots up sometimes. Any thoughts there?
It's hard to know without doing a physical exam when it comes to any orthopedic issue. At the top of my mind, I think of different tendon issues like de Quervain's would be a type of tendonitis that can start in the thumb and kind of shoot up the arms. And we saw a lot of that with people who are using their thumbs or texting quite a bit. So that's a possibility. Certainly if you've had a prior injury or any recent injury, want to probably get that checked out just to make sure there's no fracture, anything like that. Arthritis is another possibility. Or people can even get gout or things similar to gout, like pseudo-gout in the joint, especially if there's like red, heat, swelling, those types of things.
Yeah. One thing, people know about carpal tunnel syndrome, and, granted, that's usually more numbness and tingling and such, but I've had people complain of pain that shoots up even from carpal tunnel.
And sometimes for carpal tunnel, which, again, many people are going to get as they age, but even younger patients, especially now that we're using our phones and thumbs and things all day long, the night splints are very helpful, which you can get over the counter. They look like any wrist splint, to be honest, but sometimes just wearing those at night when you go to bed helps keep that tunnel open, where the median nerve, which is what we focus on with carpal tunnel, it helps keep that open so you don't have symptoms as bad the next day. I also really like Voltaren gel over the counter for wrist issues. That's been over the counter for a few years, which is great. And so those things can be helpful, but certainly if not getting better, I'd probably get checked out because some of those tendon issues do require a steroid injection or further interventions.
Now let's move up from the shoulder up to the neck. This emailer says, my neck muscles are very tight and causing headaches. What can I do to loosen those muscles? It seems like a never-ending cycle. So it sounds like some tension headaches here, which are super common. What do you recommend there?
Yeah, so really there's a lot of different things we can do to release muscle tension. This could be something as simple as I'm going to do a home stretching routine. There's lots of different options available on YouTube and things like that to provide some guidance there. I have many people that do regular massage therapy just to help loosen those muscles. That can be costly and it's not always covered by insurance. So I recommend people consider getting what's called a Theracane, which you can even buy on Amazon, that looks kind of like a shepherd hook, and you can do a little bit of your own trigger point work with that on the neck to help loosen up some of those muscles, to just try to keep those loosened up. But oftentimes it can be chronic. So especially stress or I slept wrong, you might notice that it flares up, and going back to those measures to try to loosen them up can be advisable.
Yeah, absolutely. I might add, heat, a hot tub or something, just to help heating pad, sometimes loosen those muscles, but then the movement and the stretches are key there. Absolutely. This person from Facebook says, my son was recently tested and diagnosed with a milk allergy. He has had eczema, sometimes bad, for years. Could this allergy be linked to his eczema?
So this is not uncommon, not just with milk, but a lot of foods. There's a classic triad of allergies, eczema, and asthma. Hopefully he doesn't develop the latter, but the other two can sometimes go hand in hand. So the only way to really see if that's the case is to go on a milk-free diet, a dairy-free diet if it was specifically dairy, and just see over time. There's a lot of basic over-the-counter cares, though, that work great with eczema that I think if more people did, we'd see less of it. I like plain old Aquaphor, Eucerin. Sometimes people do Aveeno, CeraVe, Cetaphil. It's best to do those after a bath or shower because it locks the moisture in. And it's been incredibly dry in South Dakota this last month. So I'm seeing way more eczema, dermatitis flares than I've probably seen in winters for a while. And so I'd pursue those routes as well while we wait and see if the dairy milk issue was playing a role or not the longer we're off the diet.
Yeah, super common problem around here. The heaters turn on, the air dries out, and there you are. Recently, I felt very fatigued, even though I get to sleep at a normal time. Could this just be this winter season, or should I go in to see if something else? When someone's fatigued, when do you recommend getting that checked out?
So if it's becoming extremely persistent, and certainly if it reaches the point of interfering with your day-to-day activities, then I think it's a good idea to talk to your physician about other potential causes. Fatigue is a tough one because the differential or things that could be contributing is extremely variable and wide. And sometimes we don't ever figure out a cause for why someone is feeling fatigued. But there's typically some blood tests that can be done. Oftentimes I recommend an evaluation for sleep apnea to make sure that we're actually getting good restful sleep. A mood evaluation to make sure that there's no contributing underlying depression that could be contributing. And definitely other things like getting regular exercise, avoiding processed foods in the diet. All of those things can help lessen fatigue as well.
Yeah, absolutely.
I will say I think sleep apnea is highly underdiagnosed. I think a lot of people think it's just obese people or elderly that have it, but I see a lot of young, healthy, fit people that have it. And most of the time you don't know it because you're not awake, and so you don't know if you're pausing to breathe or snoring or what. So I always ask the spouse. That's always my first question is, what does your spouse say or somebody else say about your sleep? But if we're not sure, many of the sleep studies we do at home, rarely do we actually do them in the hospital anymore. And so I know that was a holdup in the past, but the strong majority of mine are at home, and there are even some online programs I'll use if they're not covered by insurance to make it more affordable. And they're very easy to get. And I am often surprised how often that is the culprit, even when you would least suspect it.
I think next month I have a show on sleep apnea, so
there you go.
We'll do a whole show on it. But definitely on the list of possibilities when there's fatigue, sleepiness, and certainly if someone's noticed that you're snoring or even pausing in your breathing. Because it's amazing how treatment can decrease your risk of heart attacks and strokes and decrease your risk of dementia and help you feel more alert, more more energy, and then now you have the energy to be exercising or doing something healthy rather than just sitting around eating. So it can be a vicious cycle sometimes. Well, social media has become a powerful space, influencing not just how we connect, but how we feel about ourselves and the world around us. More than just photos and updates, it's a platform where emotions are expressed and shaped. Prairie Doc spoke with Nikki Eining, a licensed clinical social worker and pediatric mental health care access program coordinator for the University of South Dakota Stanford School of Medicine, about the link between emotional well-being and digital media.
Eining shares an acronym called the Ruler Method that can help how we identify how we may feel and respond to emotions.
That first start is, how do we really get good at recognizing our own body foods or body sensations? So what am I feeling or noticing inside my body? How can I just notice or recognize again that recognize that uncomfort or comfort level inside my body, or that energy level inside my body? And then as we get good at that recognition, we can get into some of those more complex sensations. That you is really, how do I understand that attuning to that sensation or that body pool of mine? If I tune to that and do something with that, I can have more control over the outcome of what I'm experiencing. So I can label what's happening inside, and that gives me a more sense of control. I can express it, whether that's verbally, non-verbally, physically. So we see a lot of youth and even adults, if I have a pretty uncomfortable sensation or body cool, part of that expression could be, maybe I have to go for a run, or I have to move my body, or I have to walk, or I have to journal, or I have to communicate with somebody. So that expression. And then that last R, when we talk about regulation. So what are some skills that help me regulate that emotion?
She says the use of social media can create avoidance when it comes to checking on our emotions and sensations.
Right, we're interested in the material that we're engaged in. So whether it's a game, a video game, social media platform, communicating with somebody via text, right, we're engaged and our focus is on what we're doing on that platform. That tends to distract us from paying attention to those sensations in our body. And so what happens is sometimes we utilize technology or digital media as a way to avoid that sensation. The other complexity related to technology, digital media, social media, is there are pieces where endorphins are released into our body. So dopamine is one that we should educate ourselves about. If I'm on social media and I'm looking for comments on my post or likes on my post, and I'm looking at my Instagram photo and I'm looking at how many people commented or liked that or reshared it, that releases dopamine into my system. And so there's this reward center loop that is associated with digital media, with social media.
Eining says knowing yourself and your boundaries are very important.
So when we talk about screen time, especially, what is the need that we're coming to the social media for? And so sometimes social media can be really beneficial. Maybe it's, a way for me to communicate with my family that I don't get to see very often, and it's our form of connection. We can see, social media is beneficial for that. But how do I really, again, learn about those body clues and sensations so that I can recognize what's the boundary for me? And that's really vital for us to teach, and not only for ourselves, but for our youth. And if we don't have those skills, it's really hard as adults to model that and teach that to our youth.
What an important thing to consider, and it's true for all of us, to be conscious of the amount of time on our phones and devices, and how do you address that with your patients and maybe the kids that you're seeing?
Yeah, so I think this has really just exploded, especially with now kids having access to iPads, you know, at an extremely young age. And there used to be really strict guidelines, you know, less than 2 hours is, you know, the daily recommendation for that. And those guidelines got a little bit more gray. The big thing that we recommend is that if kids are on screens, that it is time spent with parents. So if you're doing something together, reading a book on a tablet, doing a game on a tablet together, that together time is important because we don't want the iPad or the phone to replace social interaction. So really important that we're not using it in that capacity. And also just important to make sure your parental controls are set up. So there's a lot of scary places that kids can get into on the internet and different YouTube channels, and just really important to have all of that set up. And the final thing is sleep. So I unfortunately see a lot more kids that are really struggling with sleep, and we don't recommend sleeping medications for children, but really avoidance of that screen time. And that's not just iPads or phones, that's TV exposure in the evenings. If we can try to get rid of that, switch over to books, be reading books with your child, that's going to help them develop those healthy sleep habits.
I usually recommend keeping the phone in a public area overnight, you know, charging. And sometimes they say, well, we need it as an alarm clock. You can get a cheap alarm clock that might even be a little more dependable and not so tempting to grab in the middle of the night and then just mess with your sleep. Because
Absolutely.
you know, 5 minutes you're not asleep, you want to grab that phone and look at it. And that's not just true for kids. That's true for any of us. Yeah, good stuff. Let's jump back into it. This person says in email says, I have a mole that has always been larger, but is now itching and looks like it wants to peel. It has not changed color or shape. Should this be something I should have taken off? Do I need to go see a dermatologist, or could my PCP look at it? What would you say there, Ben?
So it's tough to give a definitive answer without seeing the actual mole. But what I'll say is this: I give all my patients an A, B, C, D, E of things to watch for. So I'll just go through them, and there you can find guides online that will show you pictures of what I mean. But A is asymmetry, so if one side is different than the other. B is the border, if it starts to get jagged and less circular. C is color. I don't care so much how dark or light it is, but if it changes color, sometimes I describe like a marbling, if it isn't uniform throughout. D is diameter. Now, we often say bigger than a pencil eraser, we get concerned. I'll talk about the caveat to that at the end of this. And then E is everything else or evolving. So the itching and peeling here is probably one thing that concerns me, but there are something else many people get with age called seborrheic keratoses. We lovingly call them age spots. And some people aren't that old when they get them, but they can look like a mole and be concerning to patients, but without looking at it, it's hard to say. So this is where I'd say, hey, just call your primary dermatology books out often a long ways. And so it'd be very easy to just start with your primary and have them look at this just to make sure it's not melanoma or something of that nature.
Yeah, thankfully sometimes they can tell if it's a seborrheic keratosis, but if we have to do a biopsy, that can be usually something most primary care docs can handle too, or refer if need be. Absolutely. My mother passed away 10 years ago, and I know had a hysterectomy when she was in her late 40s. I am now perimenopausal and want to know why she had it and what prompted that surgery. Is there a way to ask for those records so I know more about my own genetic history? My dad does not remember why it was needed. What would you recommend if you had a patient asking about that?
You know, it's difficult to know. It depends on if you know the clinic where any of that work was done at. Sometimes family members, other family members may have a little bit more knowledge, whether that be siblings of the affected family member, or even if you potentially know the diagnosis, was this related to heavy bleeding? Was this related to pelvic pain? Was there any history of there's a lot of things that if you knew any symptoms leading up, you could have a conversation with your doctor to figure out what might have been the diagnosis that would have resulted in needing the hysterectomy. But definitely there's a lot of reasons why hysterectomies occur, so it is really difficult to know without having that background symptom knowledge.
Yeah, it can be hard for the records because some of these medical record systems have changed a couple times, and some of them are getting rid of their older paper records.
And many places just have to keep medical records for 10 years. And so if it's before that, those can be very difficult to find, unfortunately.
Worth asking, though.
Yes.
Absolutely. I was helping my elderly mom clean out bins in her house, and we found rats' nests in several bins. She touched several of the nests and did not want to throw out the items that were touching those nests. For safety purposes, should we throw away all those items because of possible disease contamination? Without getting in the middle of an argument between someone and their mother, what would you recommend?
That sounds tense. Yes. You know, that's tough because there are certain viruses, you know, mouse droppings and things like that can carry that are concerning. However, transmission isn't always super high. I'll leave it up to them to decide whether or not to keep everything or throw it. But I would just watch yourself for respiratory symptoms are kind of the biggest thing we watch for with these. I think it's rather rare in the upper Midwest. There are certain parts of the country where they see this more. I forget the actor, but some actor died this last year of hantavirus, which can come from these. That's usually in the desert Southwest. But yeah, safest thing would probably be getting rid of them, but I don't think that's always necessarily the case, depending on how much or how recent the exposure was or all of that. The main thing is just to watch for symptoms. There's nothing else preventative medically we would do.
Yeah. I mean, they could probably wear a mask and gloves
Yes.
while they're looking through
Yes.
stuff, but
Yes.
yeah. Hard situation. This person said they had a live Christmas tree for over 20 years in their house and zero allergy issues. But this year they had constant itching and felt like they had a cold the entire holiday season when it was up. Can I develop an allergy to trees later in life when it has not bothered me in the past? Because when the tree was gone, the symptoms got better.
It is possible for allergies to change, whether that mean get better or potentially get worse during our lifetime. So it is a possibility. I think the fact that getting rid of the tree seemed to improve the symptoms would be suggestive. And there are things that we can do if you really have your heart set on a real tree that can lessen symptoms. So simple over-the-counter antihistamines like Allegra. Nasal sprays are great, especially Flonase, just one spray in each nostril daily, again, available over the counter. And those would be easy interventions that could at least help mitigate symptoms.
Yeah. And hopefully maybe it was just that one tree from a certain place and the
Possible.
next tree is
Yes.
going to be fine.
Yeah.
But yeah, certainly you do notice sometimes people acquire allergies over time. Let's talk about gallbladder issues. My sister has been struggling with gallstones, but she has not stopped drinking alcohol. Does this worsen her gallstones? What would you say to that?
So it very likely could be a factor. The gallbladder is basically attached to the liver, so yes, there's a lot of risk there, but there's a lot of other risk factors too. The diet is incredibly important with this, so greasy foods, fatty foods, heavy foods, portion size, those are all going to matter quite significantly. The other thing I'd say is there are certain other demographics that are higher risk, so women are more likely to have gallbladder issues than men. Interestingly, Caucasians and fair-skinned people often have more, and sometimes weight and things like that play a role. So there's just a lot of factors here, but alcohol certainly could be one. If not getting better, though, that is something where you might want to certainly talk with your doctor about it or have her see them, I guess, in this scenario, because there are times this can cause infection and more severe issues down the road, affect the pancreas and liver. So if people are having these issues, we typically get some lab work and an ultrasound to see if there's more extensive damage or if it should just be removed so this doesn't keep happening.
Right along those lines, this next caller had a CAT scan for an unrelated reason and discovered they had gallstones. So they're wondering, what are they? What are they made of? Or what are the symptoms? Or if they should do anything about it. So those incidental gallstones.
Correct, yes. And that's what I was going to bring up too, is the other tricky thing with gallbladder is that gallstones are common. So we always also want to make sure, do we think that realistically the gallstones are what's causing my symptoms? And do I have symptoms? Because if we find it incidentally, or if the sister's symptoms are really not consistent with gallbladder issues, which is typically I eat something fatty and all of a sudden I get pain right under my rib cage on the right side. If it's not consistent with that, then we really should consider whether or not it's going to improve our outcomes if we take the gallbladder out. Many people are able to manage with dietary changes alone, and certainly there are adverse effects of taking the gallbladder out, such as diarrhea, especially for the first year after. So it's really important that we delineate if that's truly contributing to a patient's symptoms.
Yeah, good point. Next question, is there anything that can be done about menstrual migraines? Are sufferers just destined to die a little bit each month? Oh, the next thing that's worked for me is Nurtec, but that's prohibitively expensive. Any other recommendations? So menstrual migraines, what would you recommend?
So we can treat menstrual migraines similar to regular migraines. So there's multiple different medication options for what we call abortive therapy, which is I have a migraine, I need to take a medication to get rid of it. And Nurtec, it is a great option, but it can be cost prohibitive. There's other classes of medication called triptans, which we can use during the time of that week if we need to. If people are getting a lot of migraines or needing multiple doses of medications per month to get rid of the headache, then sometimes we even think about prophylactic therapy. And that is some blood pressure medications, some mood medications. There are even anti-seizure medications that we can use to reduce the frequency of migraines. Or I have simply had women that if we can stop their menstrual cycle, then we can reduce the frequency of migraines. So talking to your doctor about ways to do that, which is typically through hormonal contraceptives.
Absolutely. We just did a kidney show a few weeks ago, but this caller asked, are there alternatives for kidneys to having dialysis? If so, are these options painful? Over 80, transplant is not an option.
Yeah, that is really tough, because when you're at the point of dialysis, there are not really good alternative options beyond what they mentioned as transplant. Now, there are times, we can watch with medications and hydration and diet and things like that to see if some of the kidney function can recover. But when your kidney function gets that low that you're to the point of dialysis, it's really tough to find anything else. And this really is kind of a life or death scenario at a certain point if it gets that low.
Yeah. I might add, there are home options.
Yes, so you don't have to go in, because I don't think a lot of people realize how significant dialysis is. It's a commitment and a half. You typically have to go in for 3 sessions a week. They're usually at least 4 hours. You get a fistula or an IV. So, there's just a lot to dialysis, and once you start it, rarely do you stop. Typically you have to stay on it.
It is a lot,
Yes.
but, I had to roll in during that show of
Yes.
there's so many people that now they feel better, and
They
now
do.
they're living their
They
life.
do, and most dialysis patients you talk to are happy they're doing it. It's helping them a lot, so they're doing it. But I get why this person is asking this question.
Yeah.
But the home dialysis has been great. I'm not sure how long we've been doing that, but that is a good option, and I do think a lot of places in South Dakota have that set up to make it easier from a transportation and issue and things like that.
You can watch old shows on Prairie Doc on YouTube, or go to our Facebook page or our website, prairiedoc.org. So I think that's, yeah. Let's go back to cold and flu stuff. If you have bronchitis, what can help with the cough? What do you recommend?
Oh, great question. So we wish cough was easier to treat than it is. There's not a lot of great evidence-based interventions for cough. For a person that does not have underlying lung disease, so like COPD or asthma, because sometimes those do require extra medications like inhalers or steroids. For the average person with bronchitis, which is typically caused by a virus, honey can be a great intervention. Just a teaspoon of honey, whether that's on toast, mixed with tea, mixed with milk, however you want to do it, that actually has good evidence for benefit. I recommend a lot of dextromethorphan or Delsum. Over the counter. Doesn't have great evidence for benefit, but that can be an intervention that people can use that is generally safe for most people to try as well.
Along those lines, this other emailer says, my husband had flu 2 weeks ago and is still coughing. Enough that it keeps him awake at night. He does not want to go in, but should the coughing last this long? When do I insist they go in?
So not totally abnormal. It can be 1 to 2 weeks after, but if he's not improving, and certainly if you start getting fevers again, that can sometimes be concerning to us that, hey, not only did they have influenza first, but you can develop a pneumonia on top. It doesn't sound like he's progressing in terms of severity, but the 2-week mark is a mark sometimes they say, hey, probably at that point you should be seen, just to make sure it's nothing more that's going to progress into a pneumonia or something more severe.
Yeah, you see this post-infectious bronchospasm too, that it's just hard to get it calmed down. It's, sometimes we'll do steroids, but they have side effects too, but worth checking in again. Evaluate if it's been a couple weeks.
I frequently tell people, if the only symptom you have left is cough and everything else has gotten better, it's likely this post-viral bronchospasm, and it's just going to take time to get itself better. But definitely progressive symptoms, new fevers, all of a sudden new productive cough, those would be things to get checked out.
Absolutely. Well, head lice are small insects that live on human heads. While these pests can be uncomfortable and bothersome, they are not carriers of disease. Prairie Doc spoke with Dana Hone, a registered nurse at Madera Elementary School in Brookings, about this condition and what needs to be done to get rid of the lice.
They are transmitted by direct contact, so it has to be from person to person. They do not jump, they do not fly. So by sharing helmets or hats or hairbrushes, a sleepover where lots of children are laying next to each other, that's how they would be spread.
Home states they follow the CDC guidelines when it comes to a live infestation.
They are not on the exclusion list, meaning that we don't send kids home What we do is notify the family. We can help provide treatment to the families if it is needed, but we just recommend that the child be treated that night or as soon as they can before returning to school the next day.
She says that if a child has lice, their family should also be checked.
So there are a couple different brands that you can buy just over the counter. They all essentially do the same thing. The kits will come with a chemical that you apply to the hair, but it'll also come with a knit comb. And that's the actually the most important step in treatment is knit combing through the hair, very particularly for probably a week at a time, doing it either every day or every other day to make sure that you're getting all of those nits or eggs off of the hair shaft to avoid the whole cycle repeating.
Although it's rare, Hone says it's important to watch for any infection on the scalp due to lice.
So it's pretty rare, but one complication that can happen is just like an infection of the scalp if they are itching and it turns into sores. So once the lice are gone and taken care of, they shouldn't experience the itching for much longer. A common misconception is that lice is attributed to poor hygiene, and it's actually not. It can happen to anybody, and they don't transmit any diseases, so it's just more of a nuisance, and it can be a week to 2 week, even longer process if you're not diligent in that knit combing.
Yeah, it kind of makes you itchy just thinking about it. Yeah. Are there any other insects or things that people should be aware of that you'd recommend, like scabies maybe or something? Or?
Yeah, so scabies, I don't see a lot of it. It's definitely around, but I don't see a lot of it. That usually affects the palms, of course. But lice, yes, that obviously schools and preschools, it feels like every year there's some outbreak somewhere for that. And then of course ticks, and I'm sure you've done shows on limes and ticks, but yes, that's another one we make sure you get the whole thing removed. You watch for a rash that's a red bullseye, things like that with that one.
Yeah, the scabies can be tricky sometimes.
Yeah.
It can leave them itchy and in different specific areas, but and maybe they stayed at a motel or slept on someone's couch or something, and so it can be hard. This person from email says their child seems to bruise easily. Should I be concerned about this? Can people just be more sensitive? They do not linger or last very long. What do you recommend with a child bruising easily?
So it's variable. I mean, most of the time, kids with bruises, not necessarily going to be anything to worry about. So kids, they fall a lot, they kind of run into things, they tend to be a bit clumsy, and so frequently, especially if it's into distribution, like the lower legs, for example, then that would be less concerning. Things to really watch for is if you start to see some like bright red dots on the skin, that can be signs of low platelets, for example, and that would be something that you want to get evaluated. Bruising that's in a bizarre distribution, so an area where a child's not bumping or landing, then that really should be evaluated. And of course, if there's any family history of blood or bleeding disorders, that should really be evaluated.
Yeah, absolutely. Let's talk about the gut. We haven't talked about that too much yet. I've had some sensitive problems with my gut for most of my life. What organs are most responsible for diarrhea? Are there long-term risks associated with taking antidiarrheals like bismuth, loperamide, kaopectate? What would you say to that?
A lot of those are great in the short term, or if you have some sort of GI bug and you need some acute relief, those sometimes can be the right answer. But long term, those aren't really ideal for this. And this is tough because there's a lot of different causes. There's things that are like celiac disease or Crohn's, but a lot of people don't have those diagnoses but still have this issue, and it can be their diet or something else, whether it's external or internal going on. So there's a lot of people who struggle with this, and a lot of us, I think, start the workup and work with our GI colleagues if we need to get to that point. Where I usually start is more fiber supplementation, so I use a lot of Metamucil, and I'm amazed how many patients do that, and a lot of things improve. And I usually just start at a low dose. Even when you eat a healthy diet, the American diet is quite low in fiber, especially compared to other countries. And so a little bit of that every morning actually solves this for a lot of people. The other thing, some people will try our prebiotics, probiotics. the evidence is kind of mixed on those for certain things. So it's not that I tell people don't try them. I just don't see it work as often as I do Metamucil, fiber supplementation, things like that. There's also really helpful dietitians around the state. And so sometimes just a visit with them, sitting down, tracking your foods, that can go a long ways. And we don't have to do tons of procedures and scopes and things like that, and then can find a long-term solution. So there's just a lot of ways to approach it, but I would start pretty conservative.
Yeah, we do know that irritable bowel syndrome, which is just a chronic diarrhea condition, there's definitely food triggers. So while medications may be necessary, if we can identify those triggers, which it's difficult, there's no blood tests because these aren't true allergies, they're just sensitivities. So there's some apps out that can help people delineate that. So the Monash app is one I frequently recommend. There is like a small cost on like a smartphone to get that, MONASH. And that one keeps up to date on those high FODMAP foods, which are ones we really want to avoid. And then there's other apps like Spoonful is another one I recommend that you can scan items at the grocery store and it'll tell you this is high FODMAP, maybe avoid it, or low FODMAP. But if you're having red flag symptoms, so if you're losing weight, if you've got pain waking you up at night or symptoms waking you up at night, blood in your stool, family history of colorectal cancer, regardless of your age, those are things that really do need to be evaluated. Weight loss is another red flag. Those are things that we would not ever want to chalk up to just irritable bowel syndrome, and those require really a colonoscopy to look further.
Absolutely. Great things to look for. There was another call that brought up probiotics and prebiotics. Do you recommend those very often?
There's just not a lot of evidence, like Ben said, for utilizing those. I tell people if you try it and it made a difference, great. But if you did and they didn't, don't waste your money on it. There's been some studies that have looked at maybe if I'm taking an antibiotic, or especially if I need prolonged antibiotics for a particular condition, then maybe just to kind of keep that gut microbiome from getting wiped out, which can then increase your risk of other infections like C. diff, then perhaps to use, but just for the general population, probably not a lot of evidence.
Sure.
One supplement that has come a ways, I think it's been around for a while, but it's caught a lot of steam the last few years, is magnesium. And of course, there's different types of magnesium, but magnesium glycinate can be helpful for some of these patients as well. Often you take it at bedtime because it can help with sleep and other things. And so I've had a lot of patients benefit from that, probably more so than probiotics, actually.
Although, I've had a number of patients that started having diarrhea in their stools, and they couldn't figure it out, and they even saw someone in urgent care and saw a GI and got a colonoscopy, and then we were like, well, what if you try stopping your magnesium?
And everybody responds differently. So as Laura said, if it's helping, then fine. But certainly if it's not, I would cut those things out, because a lot of those supplements are not regulated by the FDA, so we don't always know if what's in them on the label is actually what's in the capsule or the pill or gummy. And sometimes there are sweeteners and things where I've had, patients go through scopes and this and that and find out it was just a simple supplement that they were taking that was actually their problem.
Right.
So pay attention.
Yep. This patient is an interesting discussion. This could be. This email, my wife and I share the same physician. My wife passed away recently. Today I had an appointment with our doctor and discovered she was not aware that my wife had died. Shouldn't a personal physician be aware of this information?
That's interesting, because I think there are times we probably are left out of the loop. I actually send every patient a sympathy card when they pass. It is, from primary care, it is that meaningful. Our relationships with our patients are. I usually do get a notification from the state when a death certificate is submitted, if I didn't know before then. But there are times we just aren't aware. I mean, we have thousands of patients, and so I can totally understand why this physician probably wasn't aware and probably wanted to be, and I'm sure felt very empathetic. But there are times the system is not perfect, or we don't hear for a long time what happened. I do think as our health systems grow, patients see more people, and it's hard to keep track. I do think the ones in South Dakota do great keeping us in the loop. But as systems grow, you lose some of that personal connection. And that's why I think the three of us probably went into primary care and love our jobs and our patients, is because we probably have a stronger connection than most other specialties. But there are times where things like this happen.
Yeah, sometimes there's a delay with some of the records are faxed, or it depends what hospital system they were in, or the hospitalist was taking care of them, and that they had the death certificate or something. And so unfortunately, that could happen, but it's communication is always important, and we'll keep working at it.
Yeah, and a lot of the EMRs, It's getting better, but a lot of them don't interact. So maybe the records got sent to the wrong person who was listed as a primary care provider, or maybe they thought that their primary care provider was in their health system and maybe is not in their health system. So there is a lot of areas where getting those records transferred to the person who is their primary care gets broken down.
Yeah. Ooh, this is an interesting question. That a stent put in January 13th. Wondering how soon to take a GLP-1. So,
Yeah, I mean,
a GLP-1 is?
sure. So the
Is
hot
what?
topic, and so these are the medications that people primarily use for weight loss. They originally started for diabetes. Things like Ozempic and Wegovy, Trulicity, primarily injectables. Although as of the last few weeks, we now have another oral version that is exciting. And so the main reason I like them is not so much for numbers on a scale. I care about people's weight and want to help them reach whatever their goals are, but I really like it because it's actually very beneficial often for the heart, the kidneys, your risk of diabetes. There are a number of heart patients that cardiologists send to me to start on these meds who don't have diabetes or weight issues because it's so good for the heart. I would run this by your cardiologist or your primary doctor just to make sure you're fine for it. The main reason we have to watch it around procedures is actually with anesthesia. Sometimes it backs the gut up and you can have some issues going under, and so sometimes we hold it for that purpose. So I would get clearance for them, but many of my patients who have stents, we start it not long after because it's so good for the heart and other things.
This 64-year-old female with controlled type 2 diabetes was recently told that they have stage 2 kidney failure by their primary care doctor. All I know is my number is 34 and we will check labs again in 6 months. What does that mean?
So chronic kidney disease, I think, is something that is common, but is not always communicated the best to patients. And I think it's because it is so common. So a lot of times people will say, gosh, I saw this in my chart. I wasn't really aware even that I had this. And certainly things like diabetes, other things like high blood pressure, those are going to increase your risk. Even obesity can increase your risk of having chronic kidney disease. So we take into consideration our protein in our urine and also what's called our GFR when we're looking at the levels for what that is. And when we're starting to see a trend where it's hanging out at a certain GFR range, then that's when we really start delineating that.
Glomerular filtration rate, how
Correct.
well our kidneys are working.
Yes. Mm-hmm.
And so how do you watch for that? What do you recommend?
So a lot of us are just checking this through annual exams, blood tests, and things like that. And then once we see the levels, so this person says they're stage 2, then we'll give you parameters on how frequently to check it. Now, stage 2 is nowhere near dialysis. I think the confusing thing is it's called chronic kidney disease. Patients often think, oh my goodness, I'm going to have dialysis tomorrow, and usually that is not the case.
Yeah.
But we have great medications as well as significant lifestyle interventions that can help bring this back significantly in many cases. The other thing is age factors into this calculations. There are a number of patients I have with superb kidneys, but because they are 88 or 90 or whatever, their calculation automatically says there's a little decrease there, and therefore they've moved from stage 1, where all of us are, to stage 2. And so most of the time this just is something to discuss with your physician because it may not be that worrisome, but if it is, they will certainly have tools to help you with it.
Yeah, there's a lot of times the discussion might even not start till stage 3.
Yes.
But irregardless, to protect our kidneys, what do we recommend?
So definitely we want to make sure our blood pressure is under control. We want to make sure our diabetes is under control because those are two things that are going to affect that blood supply to the kidney. But there are other things that we know make a difference. A big one is the use of NSAIDs. These are very common over-the-counter medications. So Motrin, Advil, ibuprofen, prescription example would be meloxicam or Mobic. And when we're taking these every single day or high doses, those can affect our kidneys longer term. So if your doctor has told you about chronic kidney disease and you're using a lot of those over-the-counter medications, that's a great time to reach out and figure out what are my other options here so I can avoid that exposure.
Awesome. Very good. Good discussion today, both of you. Thank you. Our winner of our quiz was Sam. A book will be sent to you shortly. We'll be back after this.
Hi, my name is Preston Holm. I serve on the Healing Words Foundation Board, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on STPB or streaming on our Prairie Doc Facebook page.
As we finish this evening's discussion, I want to thank Dr. Hoefert and Dr. Meyerink for sharing their expertise with our viewers. And thank you to all of our viewers for tuning in tonight. We appreciate your support of our mission as we continue to provide science-based health education. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight or it didn't align with our topic, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on South Dakota Public Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio, wherever podcasts can be found. Thank you for joining us for another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
Podiatry plays a crucial role in maintaining foot health, preventing complications from chronic conditions, managing pain, and supporting mobility. Step by step, understanding foot and ankle health. Next time, On Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,